Good afternoon, everybody, and thank you for joining us for another one of our Medico-Legal Assessments Group free specialist seminars. Today, we are joined by the very lovely Dr. Jeff Bertucen, consultant psychiatrist and all-round nice guy. Dr. Bertucen's worked with us for quite a long time, and he does some...
my wife, obviously.
Yes. Dr. Bertucen has a wide-ranging areas of interest for in the civil forensic space, including mood disorders, addiction medicine, emergency medicine, military psychiatry, sexual dysfunction psychiatry, and he also does some of the sexual and historical abuse matters that sadly we're seeing at the moment. Dr. Bertucen brings his expertise and experience to the topic today, which is the nexus between depression and chronic pain. At the end of the session, there'll be time for you to ask questions if you have any, or if you have to go or don't feel like speaking out, you can always type your question in the chat below. May I ask that you all please keep yourself on mute throughout the session until question time, so that noise from your workplace or home doesn't interfere with the quality of the recording. After the session, the recordings will be sent out to you, usually within the day. And of course, they're always available on our Medico-Legal Assessments Group YouTube channel, or from the menu bar on the left-hand side of your Mag Connect if you have a login to our platform. And if you don't, ask me and I'll get you one. Anyway, thank you all. And without further ado, I'll hand over to you, Dr. Bertucen.
Thank you, Michelle, very much for the introduction, and welcome friends and colleagues out there, wherever you are. I understand there's about 80 of you. So that's good. So as Michelle mentioned, my typical specialty as an IME psychiatrist is in the area of trauma of various kinds, be that civilian trauma, sexual trauma in abuse cases and so forth. But I wanted to do something a little different today, and which is outside of my usual lane, and in fact veering over, I suppose, into perhaps a related specialty in terms of pain management. Now, I want to make clear that I have no expertise or qualifications in terms of being a pain specialist or physician, but what prompted me to do the talk today was the very long-standing prevalence in my 15 years of doing IME reports of physical injuries and associated psychological sequelae. And typically the kind of situation in which this may arise would be classically the situation, let's say, of a construction worker who lifts something heavy, experiences very sudden lower back pain, which is usually confirmed by imaging as having some sort of mechanical basis. So there is a demonstrated basis for pain, and the sequelae of that, the flow on of this. So typically difficulties returning to work or incapacity to return to work, enforced isolation at home, chronic pain, obviously, which is bad enough through the day, but which can also have a very corrosive effect on sleep quality, difficulties in continuing with relationships or intimacy, and all of the other sequelae as well, loss of autonomy, having to be enforced to rely on other people to do mundane things, and so on and so forth. So very frequently we see primary physical injuries in these kinds of settings, which then go on to have very real mental health secondary sequelae. And often as IME psychiatrists, we are called upon to examine the severity and the nature of mood disorders which are secondary to these kinds of physical injuries. And also what is a bit of a challenge, I guess, in terms of answering questions in schedules of questions, such things as the requirement for personal assistance. Now, that's a question I often see in these kinds of questions. And it's a tricky one to answer because how much of the requirement for personal assistance is physical or arising on the basis of their physical injuries, and how much should we regard as psychiatric in nature? In other words, for the person with a back injury, let's say, who is depressed, how much can't they do on the basis of their physical symptoms? And to what extent might they be demotivated? May they be depressed? May they be simply lacking in impetus or desire to look after themselves? So this is often a very difficult to judge question, a very difficult situation which we have to tread around and try to give the best answers as psychiatrists that we can. So I guess with that sort of preamble, it was intriguing to me to examine this a little bit further and to look at the relationship between physical injuries and psychological sequelae or psychiatric sequelae in our claimant cohort. So I think the first thing, there's no slides, by the way, guys. I'm just going to sort of extemporize. And if I'm looking off to the side, I've just got a couple of little notes and slides here, which I can't share with you, but I'm going to be referring to on the side. So I think the first thing to understand, which is quite, I think, self-evident, is that pain and psychiatric conditions such as depression and anxiety must be seen as interrelated conditions, and they have a mutually dependent relationship. By that I mean that if the pain is severe enough or long-lasting enough, almost inevitably we're going to start to see effects on the patient's mood state and mental state. As I said, the effects of pain on sleep, grinding a person's resistance down over weeks and weeks and months, having sleep constantly being broken. Every time the patient turns over, there's some twinge of pain, getting inconsistent, poor quality of sleep, frequently broken sleep, as a result feeling very depleted and exhausted the next morning and going into the following day with low energy levels and so on and so forth. A very, very commonly seen scenario. After a while, that's going to take a psychological toll, as you can imagine, as well as the other effects through the day. For example, inability to continue with regular exercise or gym. Some of our claimants, particularly those that have physical occupations, are very fit, so often enjoy regular weight training, mountain biking, swimming, what have you. They can't do any of this stuff as a result of their pain. And that the absence of those outlets obviously can be enormously dispiriting to some people and certainly can lead to a psychiatric syndrome. Similarly, I was going to say in females, but not exclusively in females, weight gain or loss of physical tone or shape can definitely have a very negative additional impact on depression. So by mutually interdependent, the other side of that coin is that not only can pain eventually lead to a decline or a deterioration in mental state, but on the other hand, having depressed mood can also magnify or amplify the sensation of pain. In other words, the greater the depression, the more profound the depression, usually the greater the subjective sensation of suffering. So in terms of how do we deal with it, it's often very difficult to get a handle on how much physical and how much of a psychological apportionment there actually is. And because of this rather elusive mutual interdependence of pain and depression, and of course we can't get into a person's head, we can't actually tell how much pain they're actually feeling. This gives rise to a number of difficulties. The first, of course, is how genuine is the pain? Where do we, I guess, draw the line, or where do we begin to consider the possibilities that pain is either being subjectively magnified by the fact that the person is depressed, or in other situations, of course, when there is no or very little mechanical basis demonstrated for the pain, but the person keeps on complaining of pain. When, as psychiatrists, do we have to acknowledge that there is an element possibly of factitious disorder, somatization, or even deliberate malingering for gain? Obviously, in the compensation context, this is naturally not unheard of. So these are the, I suppose, the intricacies of examining patients who have a primary physical injury as a psychiatrist. I might just go off on a bit of a tangent for a second, because one of the frequently asked questions, of course, in IME examinations as a psychiatrist is the distinction between a primary and a secondary psychological injury. Now, a primary psychological injury is regarded as an injury in which, from the outset, there is an inherent psychiatric component to the injury. And as an illustration, I guess the most obvious one would be a person involved in a horrific motor vehicle accident in which maybe there's a fatality, or there is a serious injury, or they witness the approach of the car before the collision, etc., etc., etc. So in those kinds of situations, when we're looking at post-traumatic stress disorder, naturally that's what's commonly referred to as an example of a primary psychiatric injury. A secondary psychiatric or psychological injury, by contrast, is, put it simply, where something bad happens and the person gets depressed. So in the scenario that we were talking about before, in which a person on a construction site, such as my house, you can probably hear in the background, God forbid, suffers a back injury or some other kind of physical injury, can't work, is hanging around at home, can't sleep properly because of pain, they get depressed. So clearly that's what we refer to as a secondary psychological injury. There are, of course, situations where both apply. For example, the aforementioned car accident, in which the person is physically injured as well, and they have elements of post-traumatic stress disorder and depression, perhaps because of their injury. That could be regarded as a situation in which there's a mixture of primary and secondary. But in the sort of classical, let's call it the construction worker analogy, almost always these are regarded, or should be regarded, as secondary psychological injuries. And technically, the PIRS, the PIRS table, does not apply to secondary psychological injuries, but we usually do anyway. Just a couple of statistics from the 2007 National Survey of Mental Health and Wellbeing. Some of the findings were that common mental disorders occur together. In other words, mood disorders, anxiety disorders, substance disorders, and that mental disorder and physical comorbidity is common, about 30%. In situations where the person has a primary physical injury, our construction worker, again, it depends on the severity of the pain and the how far-reaching the physical disabilities are, but we can assume that the greater the pain and the more disabling the physical injury is, naturally the higher percentage of depressive comorbidities we're going to see. Excuse me 1 second. Again, looking at the kind of other comorbidities that can develop with regards to physical injuries that then take on a psychiatric dimension. In terms of diagnosis, again, this can be a bit of a topic of discussion. In terms of the strict definition, this is more a problem for psychiatrists, obviously, but is it an adjustment disorder or is it a major depressive disorder? Now, I personally regard those terms as more or less interchangeable. But if you have a look at your DSM-5, an adjustment disorder is defined as a disturbance of mood which can arise within 3 months of an identifiable stressor, and a bunch of other criteria as well in terms of significant disruption, causing or responsible for significant disruption of social, occupational, interpersonal functioning, etc. Now, the vast majority of construction worker type injuries that lead to depression, in my opinion, do conform to the definition of a chronic adjustment disorder, because the stressor that was responsible for the mood symptoms, in other words, the pain, is ongoing. It doesn't go away. So personally, in my opinion, the correct term for the psychiatric condition of depression secondary to pain should be regarded, if it's severe enough, as an chronic adjustment disorder with features of depression and anxiety. But you see the diagnosis of major depressive disorder being used as well, and I guess that's kind of true. It's more of a fine point, but that's my view. In terms of other common psychiatric conditions or comorbidities that we often see in primary physical injuries, naturally, anxiety disorders or social phobic anxiety. Often people become highly self-conscious about their injury, or if they have a limp or a problem with their gait, or a young person, for example, having to require a cane or a walking stick, you often find that these people become very self-conscious and a bit reclusive, fear being judged in public and so forth, and often meet criteria for social anxiety or social phobic anxiety disorder. Another very common comorbidity in this kind of scenario that we're discussing is the gradual development, sometimes the sudden development, or aggravation of chronic alcohol and substance use disorder. Often this can be an outgrowth of both chronic pain and depression. People can use cannabis because of its analgesic properties, of course, and this can often take on its own dimension as a substance use disorder. People frequently use alcohol and other illicit substances, but commonly alcohol, as a means of getting to sleep, getting through the pain barrier at night, boredom, and also as a means of coping with their distress and anxiety. The comorbidity of alcohol and substance use disorders in chronic pain conditions is not to be underestimated, and somewhere around the 20 to 25% figure. So again, just getting back to the etiology and the mechanism, my notes here: depression and pain are inextricably linked at the biological and experiential level. The relationship is causal and circular. Cause and effect merge. So it's the nature of the interrelationship between depression and psychiatric conditions. Chronic pain promotes depression, and depression promotes chronic pain. Now, the experience of pain, as we know, like the experience of post-traumatic stress disorder, is variable between one person, one individual, and the other, depending on a number of characteristics: the sometimes cultural background, gender background, the occupational culture, and so forth. So just as two emergency responders can be subject to the same traumatic event, and one may go on to develop post-traumatic stress disorder and the other may not, similarly, two workers may be subject to exactly the same kind of injury, One may retain a resilient mindset and be able to make a physical and psychological recovery more easily. In the other individual, as we said, because of varying and complex factors, that resilience may be absent or may not be there to the same degree, and as a result, the person's mood may spiral, and that individual may develop a mood disorder as a result of his injury, whereas the first individual may not. We're not entirely sure, obviously, as to what are the factors that may account for those differences. Neuroimaging in chronic pain has shown a number of interesting results. There are a number of brain imaging techniques such as fMRI or PET scans, which can demonstrate slight changes in brain structure in chronic pain conditions such as fibromyalgia, which is, again, almost a topic unto itself. There can be volume loss, some demyelination, and different thicknesses or different changes in the appearance of the cortex. A number of clinicians have actually utilized some more novel techniques in chronic pain sufferers, like neurofeedback, as a means of helping to reduce the subjective sensation of pain. Now, we get on to another group of pain conditions, which again are commonly seen in the IME sphere, which is somatic symptom disorder, which used to be called somatoform disorder. Now, these are a bunch of different kinds of pain and physical conditions for which there is no demonstrable medical basis for either the production of the pain or for the ongoing symptoms of pain. Many of these clients, by the time they're seen by psychiatrists, obviously have been examined by neurologists, orthopedic surgeons, pain physicians, and so forth, and have been subject to the relevant investigations. But despite sometimes being exhaustively investigated, we're not able to discern a readily identifiable mechanism for why these people are getting pain. So this is a very difficult predicament, I suppose, for the psychiatrist, because we are in many ways forced into a diagnosis of somatic symptom disorder based on the evidence of our colleagues, our physician colleagues' reports. If nothing can be demonstrated and there are no other potential competing causes for why the person is depressed, apart from the pain that they claim they're suffering, we are, as psychiatrists, generally kind of obliged to throw our hands in the air and say, look, by exclusion, this must be a somatic symptom disorder. Very occasionally, we might make a diagnosis of conversion disorder, which is an interesting and quite variable syndrome of neurological symptoms, some of which can be quite bizarre, again, for which there is no demonstrable explanation, having been examined by a neurologist and subject to the relevant tests. Occasionally, of course, we might make a diagnosis of malingering if we believe that there is a history of same, if the person maybe has a forensic history, is an unreliable historian for various reasons. In terms of the AMA5 or AMA4 PIRS guidelines, as I'm sure many of you would be aware, somatic symptom disorder is an exclusion from being able to, a person that has a diagnosis of somatic symptom disorder is excluded from the PIRS framework, and we're unable to provide a conventional figure for impairment assessment for these people. So in terms of management, I guess in abstract terms, where we have a situation in which clearly there is a demonstrable physical injury and the person also has equally demonstrable signs of a mood disorder or a psychiatric condition, there really needs to be a multidisciplinary and coordinated approach. In effect, we are, as psychiatrists, nibbling away at one end of the problem, and our pain physician colleagues can be seen as nibbling away from the other end of the problem. And in tandem, evidence and trials have shown that a pain management approach in combination with a mental health approach ultimately yields better results in terms of treatment outcomes, certainly more so than either approach on their own. And I think this realization has obviously driven the growth of pain management clinics in the last certainly 10 or 15 years that I've been involved, which incorporate mental health services in these clinics. So you'll probably find most pain management clinics now very sensibly have an in-house psychologist to assist in terms of just providing adjunctive treatment to the pain management treatment. So what can psychology do? I mean, I often find that patients with severe injuries are a bit skeptical of psychological therapies, or perhaps a bit disillusioned, having had psychological therapy and come away saying, well, look, you can talk about it all you like, but it doesn't change the reality of the situation. You know, when I walk out of the psychologist's office, I'm still in pain, and it might feel better to, you know, hear the pep talk while I'm sitting opposite the psychologist, but the benefits don't last much longer than when they walk out of the room. And for psychological therapy on its own, as a mental health treatment, I think that might be fairly reasonable, I guess, for patients to assume this, which is why the combination of psychological therapies and some pharmacotherapies in tandem are recommended as best practice from the point of view of psychiatric management of chronic pain conditions, or depression in chronic pain, rather. Psychological therapy, though, has a number of benefits, and certainly over the medium to long term, the goals of psychological therapy broadly are to help the patient manage the degree of distress associated with pain. In other words, to normalize pain as much as possible, to help the patient be able to regulate their own affect and mood a little bit better. Of course, chronic pain can often make people very irritable, very cranky, which can lead to all kinds of family and interpersonal negative consequences. So better affective regulation, helping to process the reality of pain and helping the person adjust and accept to a degree the normalization of a life with pain. So these are the sort of broad outcomes and benefits of psychological therapy. In terms of what we as psychiatrists might use as pharmacotherapy, there are a number of antidepressant agents which have analgesic applications that are used probably more than others. The first ones are the older tricyclic antidepressants, such as amitriptyline and nortriptyline. Now, these have reputed benefits in terms of managing the neurological or neuropathic component of pain, and are also quite sedating, so normally given at night to help the person get to sleep. In my own practice, in terms of clinical practice, if I'm managing somebody with depression and chronic pain, the paramount goal, I think the first paramount goal, in my opinion, is to try to normalize sleep quality as much as possible, to get the person, for the first time in ages, to have as sound and unbroken sleep as they possibly can. If you can minimize the frequency of disturbances in sleep, in many cases, the person will wake up feeling more refreshed. As a result, will be more motivated and optimistic, and generally have more impetus to engage in self-care routines, look after their children, get through the day, whatever. So I think management of sleep irregularities is, in my view, a really important early goal in addressing mood disorders in chronic pain conditions. Some of the other newer agents which can be used are duloxetine, which is Cymbalta, which is an SNRI, a serotonergic and noradrenergic reuptake antidepressant. It's initially it was a bit of a moot point as to whether Cymbalta was more of a marketing exercise or whether it did in fact have some demonstrable benefits in pain. But there have been some recent studies which tend to suggest that drugs like duloxetine do have statistically significant analgesic effects. Just about any antidepressant will make a difference. And here again, we have to sometimes overcome the reluctance of many of our claimants to seek and receive psychiatric treatments. In many, many cases, when I interview injured workers, often there is a great reluctance either to acknowledge that there may be a psychiatric component to their condition in the first place, and secondly, to overcome entrenched prejudices and skepticism regarding seeking mental health treatments in terms of psychological therapy or psychiatrists. It's unusual. You would think that that would not be the case, but it is in fact quite prevalent. And particularly prevalent, if I may again just go on a tangent here, in determining treatments, we also have to be very sensitive to cultural differences in the perception and expression of pain in two ways, I think in two major ways. Firstly, certain cultures, getting back to the previous point, tend to be more resistant than others to the idea of seeking and receiving mental health treatments, even for primary psychiatric conditions, let alone this kind of situation in which we're discussing. Not necessarily to identify any particular cultures, but I see time and again injured workers, maybe from, let's say, Southern Europe or Eastern Europe, but certainly not confined to those areas, talk about cultural stereotypes of seeing a psychiatrist. If you're crazy, I'm not crazy. I don't need to see a psychiatrist. And in many cases, the absence of mental health treatments in these individuals means that their pain gets worse, their sleep disturbance continues, they continue to suffer, and treatment is delayed, sometimes indefinitely. The other side to this coin is that in many cases, pain and physical symptoms can be a cultural expression of depressed mood. And this is, again, particularly common in which cultures which fail to recognize adequately depression and anxiety, or perhaps don't have the cultural vocabulary or the cultural lexicon to express symptoms of depression and anxiety. Often these conditions, these mood disorders, are expressed externally as pain symptoms. I have a headache, chronic back pain, unexplained lethargy, having to lie down. And I think it's really important to be attuned as psychiatrists to these kinds of cultural variations in how pain is expressed. Pain is not always pain, or I should say, pain is not always injury. The pain is perceived as pain, sometimes expressed as pain, but not necessarily primarily due to a demonstrable injury. And this can be a cultural bias. And I think it's really very important as clinicians that we are sensitive to this and we're attuned to the possibilities of this being the case. Just finally, in terms of novel treatments, transcranial magnetic stimulation, or TMS, has an evidence base of success in the treatment of depression in people with chronic pain. And again, TMS is very interesting. Firstly, it works, and there is enough statistical evidence to demonstrate that it does work, but it can have a kind of placebo, and this is no disrespect to TMS, but in many of these individuals we were talking about, in which using medications, taking drugs, inverted commas, is unacceptable or is highly undesirable, and the situation is obviously not severe enough to use ECT or electroconvulsive therapy, TMS can actually be a very effective third way, or kind of middle path, which can allow patients with depression and chronic pain to get better without losing face. This is a very difficult concept to articulate, I think, but in the case of many people who are highly reluctant to use pharmacotherapies, TMS can be an acceptable alternative and a pathway to recovery for this group. Finally, just to mention the potential for other, I guess, peripheral treatments, particularly cannabis oil in its medicinal form. Now, CBD oil is gaining increasing popularity throughout Australia as a treatment, not only for anxiety disorders and post-traumatic stress disorder, but particularly in depression or PTSD, where there is a chronic pain component. And as we said, from the point of view of comorbidities, this is pretty common. CBD oil is available in various forms. It is obtainable from parallel sources. It can be sourced from the internet, and again, the results anecdotally in the patients that I deal with are overwhelmingly very positive. Many patients using CBD oil report marked improvement in sleep quality, don't wake up through the night. They report an excellent analgesic effect, improvement of anxiety symptoms, and their mobility and alertness and cognitive capacities are generally not impaired, or at least not significantly impaired. So CBD oil is rapidly gaining ground, and I think perhaps with some justification, as an adjunctive or complementary treatment of mood disorders and anxiety disorders in the presence of pain. The other one, lastly, that I want to mention is the possibility of intranasal esketamine, which is now being rolled out or gaining increasing acceptance across Australia as primarily a treatment for depression. As we know, ketamine is used as a very widely administered analgesic agent, either by infusion or injection. And esketamine, which is a structural analog of ketamine, is also showing some promising early signs of being a useful agent in the treatment of depression with chronic pain as well, even though the manufacturers, Janssen, are a little coy about promoting esketamine as having any sort of distinct benefits from the point of view of pain management. It's certainly being marketed overwhelmingly as a treatment for depression. But anecdotally, we're starting to see that our depression and chronic pain cohort who are using intranasal esketamine generally twice a week also report improvement in the subjective perception of pain symptoms. So this is potentially very, very promising. So I'd like to stop there. I know that's probably a very potted overview, and I've probably left a lot of things out because it's a broad topic. But
it is indeed.
Dr.
Bertucen, that was outstanding. That was really, really, really excellent. And it's funny, as you spoke, I ticked off 4 questions that I had from people who have been unable to attend today, 3 lawyers and an insurer's case manager. The insurer's case manager was asking about neurofeedback, specifically in relation to current research that does not support conclusive results, which you covered. Another was talking about Cymbalta, and another one was talking about TMS. And then the third was talking about going back to the old antidepressants bracket tricyclics. So you
All of
covered
which,
all of those things in your talk. Does anyone here have a question that they would like to ask? You can unmute yourself to do so or type it into the chat. Looks no. When that happens, it's because you've covered everything. But I do have one question of my own.
sure.
And the question is in relation to cases that we see here coming across our desks at MAG, that one of the things that we see anecdotally spoken about by psychiatrists in their reports is therapy to help people reduce preoccupation and avoidance behaviours. And I wonder if you could just quickly speak to that.
Well, I mean, preoccupation, I guess, refers to the situation that injured workers find themselves in when they're stuck at home. They can't work and they're bored and they have little else to do apart from ruminate about and be preoccupied with their pain. And this is why diversional therapy, vocational rehabilitation, things like having a regular, perhaps, gym regime or seeing an exercise physiologist can be very helpful in providing structure for people who are disabled because of pain or work-related injuries. Boredom is a dreadful thing, and it's the lack of structure in many cases that contributes greatly to decline in mood and to depressed mood. So if any opportunities can be provided to prevent people from having that time to be preoccupied with their injury and preoccupied with pain, that's extremely valuable. So as we said, occupational therapy, diversional therapy, EP regimes, vocational assessment to look at perhaps redeployment to alternative suitable duties when it's appropriate, of course. All of these sorts of things are very important. What was the second thing that you mentioned?
Was avoidance behaviours.
Avoidance behaviours. Well, this is, again, I think, falls into the realm of the benefits of psychological therapy. Psychologists are very good in terms of cognitive therapy, helping people to overcome their anxiety about being hurt if they do X, Y, or Z. And many people with chronic pain conditions are naturally terrified of the prospect of experiencing further pain if they were to mow their lawns, do bowls, gardening, all of the things that they used to enjoy doing. So there is a kind of a great generalized constraint that often depressed pain sufferers experience. Their world contracts due to the expectation of pain if they do anything. So avoidant behavior is one of the goals, or it's one of the, I suppose, the areas of attack that psychologists work on to help overcome that barrier and train people to get on with things, perhaps despite the possibility of pain.
Cool. Now we've got just one last question for you, and it's something that also occurred to me. Does or should the use of CBD oil result in restrictions on being able to legally drive? And I guess that includes also operate plant and equipment in context with the job.
Yes.
And where does it say? And are there options that don't require driving restrictions?
From what I understand, there are several variants of CBD oil, some which is just cannabidiol and some that have THC, tetrahydrocannabidiol, as well. And it is, from my understanding, the THC component, which is the prohibitive component with regards to certainly roadside police drug testing. CBD oil without THC, I understand, has no such restrictions, and certification can be provided if a person is using CBD oil for therapeutic purposes.
Fantastic. I will let this one question sneak through. Last question, because it is a good one. How do you tell the degree of pre-existing depression that is impacting on the current situation?
Well, I mean, certainly in terms of taking a thorough psychiatric history, we always take account in detail of any possibility of pre-existing psychiatric conditions. So, well, if they exist, obviously they exist. And in many cases, physical injuries, of course, aggravate or exacerbate pre-existing depression. And that has to be reflected in the report. So there has to be a great deal of diligence in examining past psychiatric history, whether there was anything immediately pre-existing the injury, if the person may have had earlier episodes of depression and might be considered a vulnerable individual to depression. And this, of course, can be reflected and influence your answers to the schedule of questions. In other words, was the work injury the substantial cause of the adjustment disorder? If the person has a pre-existing history, we can't honestly say it was the substantial cause, but we can say that it was, for example, the substantial cause of the aggravation of the pre-existing injury. So the wording changes, but definitely a full examination as much as possible. And look, you obviously, again, encounter individuals who are vague about their past psychiatric history or try to minimize it or downplay it. And this is why it's very important for IME psychiatrists to take the trouble to look through GP notes, because very, very often we note multiple mentions of depression in past years, prescription of various kinds of antidepressants that the patient may either have forgotten about or deliberately want to gloss over. So again, that kind of thoroughness is most important in the psychiatric IME interview.
Lovely. Well, look, thank you so much for your time today, Dr. Bertucen. I'm very, very grateful for your time and your expertise. We're really very, very grateful for you. And thank you, everybody, for your time today to join us. We look forward to seeing you at our next seminars. Have a great rest of the day.
Thank you. Bye-bye.
Stop the recording.